Oh, so we all ready here?
Yep.
Okay.
Recording in progress.
Oh, so we all ready here?
Yep.
Okay.
Recording
we'll
in
just wait a few
progress.
moments for everybody to log on.
Oh, so we all ready here?
Yep.
Okay.
Recording
we'll
in
just wait a few
progress.
moments for everybody to log on.
Oh, so we all ready here?
Yep.
Okay.
Recording
we'll
in
just wait a few
progress.
moments for everybody to log on.
Oh, so we all ready here?
Yep.
Okay.
Well, welcome to the AO Trauma Hand North America online series.
Recording in
progress. Fireside chat. We're going to be talking about nerve injuries and repair and reconstruction today. Dr. Marco Rizzo out of Mayo Clinic is our chair of our educational division, who spearheads a lot of this. I'm Sonu Jain. I'm out of the University of Cincinnati, and we have a wonderful faculty today. We have Dr. Harry Hoyen out of Metro Health in Cleveland, Dr. Nick Pulos from Mayo Clinic in Rochester, Minnesota, and Chelsea Taylor out of Yale in New Haven, Connecticut. These are our disclosures. This is how you can obtain CME credit for this webinar. So with respect to questions, you will submit them for the faculty to answer through the Q&A box. Here's our webinar agenda. These are our objectives. And here's our upcoming 3-case series, next one being on November 21st, looking at distal humerus fractures with the AO professor, Dr. Jesse Jupiter. And then we also have our hand series webinars, the next one being on December 4th, looking at distal radius malunion. And we also have a whole slew of hand courses as well coming up, next one being in Cincinnati and the other one following in Jacksonville. So if you're interested, you can sign up for that. You can access this recording through YouTube. And you'll get a link for that. And then obviously we have our live stream on OrthoTV. So I'm going to begin by talking about nerve injuries, the introduction of management or classification management, and also a case that should interest you. So I'm going to begin with some of the basics. So, looking at nerve injuries, we have classification for this. Initially started with Seddon, and then we've had the Sunderland modification, and then even modified by Susan McKinnon and Lee Dillon for the Sunderland 6th degree here. And basically, what you're trying to figure out is how badly damaged is the nerve. Is it a neuropraxia, which is the 1st degree? Is it an axotomesis, which is an injury within the nerve itself with loss of continuity, or is it a complete transection, which is a 5th degree, which is your neurotemesis? And so you'll see some of this play out today in our cases and our discussions. And this next slide is not to repeat that, but just kind of showing you visually what these different degree injuries are. And to be honest, a lot of what we're going to be talking about today, maybe the 6th degree, we may have multiple types of injuries within the same nerve, and that makes it a little more complex to manage, but it should be interesting. So when you have nerve injuries, factors to be aware of are looking at the type or the mechanism of the injury. Is it a sharp injury? Is it a crush? Is it both? When did this happen? Where along the extremity is it located? Is there multiple zones? And are there other injuries involved? Because that would affect your management plan. So the initial management of this basically would be doing your basic history and physical, look at the haddenness of the patient, occupation, smoking status, any other vascular, tendon, or bony injuries, and any social factors. It's timing. So when should we really address these nerve injuries? Well, there's some data that suggests that outcomes are worse with incremental monthly delay, perhaps even as long as 14 days. So the thought is you want to repair nerves within 14 days. Sensory nerves may recover later, but the quality is not as good, and the motor end plate loss may degrade as early as a year. So if you have these sensory repairs and you want to repair them within the first 14 days of first presentation, if they're arriving to in a delayed manner, if it's a mixed nerve, you really want to try to repair those within the first 24 hours of first presentation to you if they're delayed. And then the digital nerve, you have a little more leeway with. You can actually repair those within a few months if you need to. I'm not saying we would necessarily deliberately try to do that, but if they're presenting to you delayed, you have the option to repair that within the first 3 months if you're getting that. So there's an algorithm that exists out there which really kind of looks at peripheral nerve injuries and how to manage this. This is out of Annals of Plastic Surgery with Brendan McKay et al. And a whole slew of authors. And this is interesting because it kind of really looks at how to really look at nerve injuries and how to assess gaps and what to do for different gaps. And this is something you can look into as part of your algorithm and modify it to how you would like to address some of these nerve injuries. Because again, this is not dogma, but this just gives you an idea on how to do this. So direct repair end to end is best. It's not always possible, and you want to try to do this within the first few days to avoid contraction of the nerve where it sort of retracts back and you can't really get it together. Because when you do it early, you can mobilize the nerve without scar. You can potentially stimulate the distal end if you need to, if it's a motor or mixed motor nerve. And the main disadvantage is, you may not be able to assess the zone of injury as accurately, but I'm not sure if that's really as big of a deal. So when you are repairing this, what you want to do is have adequate visualization. Loop magnification is acceptable for large nerves, but for digital nerves. But if you want to use microscope, that's very reasonable as well. You want to resect the distal nerve or the distal nerve ends on each side of the nerve to healthy tissue, and you might have to resect more if the injury time is longer. And the way you determine if you have a healthy resection is you look at the fascicle structure, look for intraneural bleeding. You can palpate the nerve to see if it's firm, if you have scar tissue. And then you can also do intraoperative histology and nerve studies if you have that available. So nerve has to be freed from surrounding scar tissue. You want the nerve to be repaired in a vascularized bed. You want minimal tension on repair. We know this because tension causes ischemia, mechanical failure, and can lead to neuroma. And when you are looking at what constitutes minimal tension, well, if you can't hold the repair together with a single 9-0 nylon, then that's a sign of undue tension. That may be something that you may need to treat with an alternative technique. So for suture replacement, we place it in the epineurium. Typically, if you do it in the perineurium, you can potentially align the fascicles a little better, but you're going to cause a lot more scar tissue. So in general, we repair these with epineurial repairs, and the outcomes are not really different. So my technique is to use the microscope, microsurgical instruments, identify the nerve, laceration, debride it, use a piece of background, whatever color you have, blue, green. I'll use a piece of Esmark and use that, and then I'll sharply debride and mobilize the nerve microscopically, look for the healthy fascicles, bleeding tissue, and I'll do the epidural repair with an 8 or 9-0 nylon, depending upon the size of the nerve. And I would repair with minimal tension, with the fascicles barely touching. And if there's any fascicular escape, I will try to trim that, but I really try to avoid that scenario. So that's something that just to keep in the back of your mind. So what are the areas of nerve surgery that we have interest in? Well, so when you're looking at nerve repairs, we talk about nerve conduits and fiber and glue. And for nerve reconstruction, we have the autografts and allografts. So with respect to conduits, the data really shows that you want to limit this to nerve gaps up to about 1 centimeter in non-critical nerves, and we typically use more biologics. We're not really using the polycaprolactone conduits anymore because they have a lot of complications historically. There is also the concept of conduit assisted repair, as this may reduce tension and tension-induced ischemia on your repair, but also serves as a physical barrier potentially with axonal sprouting and to keep tissue outside tissue out. And it's semi-permeable and protective, which allows nutrient diffusion. So these are, some advantages to this that are advocated by those who do this. And this is a case of mine where I did do this. I don't typically do this on most of my nerves, but in this case, I did do this for the reasons mentioned above with the distal nerve graft reconstruction of the median nerve. Then there's some other newer generation conduits that are coming out, which have some more structure internally with it. And I think that we're looking for the data on this to see how this does as it is being clinically used. And then we have a very common scenario, which is the process nerve allograft, which we're all familiar with. And so are all very familiar with the Ranger studies and the data from that. And this one looked at 1,600 repairs, no adverse events. It showed that the best outcomes were in meaningful recovery, were in short gaps, less than 15 millimeters, mostly sensory nerves, and that it showed that even in repairs up to 70 millimeters with mixed and sensory nerves, they were comparable to autograft. But I would like to caution you that the comparisons made here due to lack of comparative autograft studies in the literature at the time. So I think we have to look at today's allograft data and with a grain of salt compared to historical autograft data. But I think that when you have 50 millimeter gaps, then you are probably in an area where you have complex injuries, which introduce variables. So in my practice, I try to limit autografts to probably no more than 3 centimeters in most cases, and I will usually use autograft after that. So the allograft is still my go-to for most nerve gaps. And this is a case of cases of allograft for digital nerve repairs, and this is where it's probably most and best used. And then this is just some basic science showing data from conduit and process nerve allograft and autograft, and you can see that the fiber count is significantly more in the autograft compared to allograft, but you can see it's still the allograft, is substantially more than the conduit in that case. So as you get to longer lengths with allograft, you definitely see a narrowing effect of the nerve regeneration, and it doesn't seem to progress as far. So this kind of is consistent with what I mentioned earlier about keeping them in a shorter gap type of repair or reconstruction. So fibrin glue, there's not really any ideal glue yet. The benefits that we like regarding it are the ease of use, and it's atraumatic, not throwing stitches. Even sutures can cause little areas of scar tissue too, right? And it's quick. So the drawbacks are you don't have the strength, and the theoretical possibility of disease transmission is probably pretty low. But I think the biggest issue is the strength, and these are the components. So there are some studies show that it does help with nerve repair in addition to sutures, but also that if you can use it and protect the repair for a couple weeks, then you have enough strength of the repair of the fibrin glue similar to sutures. But so I think this kind of supports the notion when you are using it for plexus or something like that, where you don't have much mobility and you can really protect your repair, you can do that. But I think when you're looking at more distal nerves and you can't protect it like that, then you run the risk of failure of that. So what about fat? Well, is there a role for it in the nerve repair side? Well, there's some thought that it may help. I mean, when we see nerves, they tend to be in a environment where there is fat. So when we are identifying nerves, they tend to be in that environment. So we know the nerves like that. So this is a case of mine where I don't typically do this, but it actually worked in the scenario where I could rotate a little bit of a fat flap per se around that reconstruction to see if that would help with some vascularization of that and create an environment that's more healthy for the nerve. So just food for thought. I'm not hanging my hat on that just necessarily for everything, but something to consider. What about electrical stimulation? Well, this is something that's new and up and coming and exciting. And I think there's some promise to this. And so the thought is low frequency electrical stimulation, which can be delivered at the time of surgical repair, can accelerate axonal outgrowth, remyelination, reinnervation. And there are some preclinical studies which are promising, which show that you can get accelerated regeneration with autograft. And then when we were looking at what was done, that when you had 1 hour of stim, they did show that humans had improved outcomes. And but there's also some data showing that even as little as 10 minutes can help in the rat model. And there's some studies going on to get more data in humans for that. So I think this is also fairly new, but also there is good data out there already that shows it does make a difference. So this is a case of mine that I'm going to present, which is a 24-year-old right-hand dominant male who presented just a little bit after 24 hours from a dog bite to his right index finger. He was seen right away at an outside emergency room, and he had the wound irrigated and closed, and he was put on antibiotics. But less than 24 hours after that, he presented to my clinic with worsening pain and swelling and worsened motion. And, in my mind, I'm worried more about infection in this scenario. And he did have some numbness, by the way. And we did examine him and found him to have decreased sensation in the radial digital nerve. But he also had pain in his palm and flexor sheath and had the signs that I would be more worried about in early flexor tenosynovitis, given the laceration site on the volar surface of his finger. And so since he was in my clinic and I do have a procedure room, I was able to explore the wound and form an IND in the office under, Wallant, wide awake local anesthesia, no tourniquet, and that worked well. And so I did, this photo is him after we closed, but I didn't have a photo when he presented, but he didn't have purulence within the subcutaneous tissue. He did have fluid in the flexor sheath, but it wasn't turbid. We did flush that out, and we did irrigate the subcutaneous tissue. When I was there, since I was looking at that wound and I knew he had numbness in that radial digital nerve, I did explore that area in a limited manner, and I could see that the radial digital artery was avulsed, but the radial digital nerve was intact. But it did have a type of traction injury. It wasn't healthy, wasn't great, and it probably needed some further management. But right now was not the time. We had to solve this infection. So we irrigated the wound, like I mentioned, and closed this, and I did send him to our hospital for IV antibiotics, which he did help improve his outcome. And he was diabetic, and that probably also contributed to some of his infection state, that he wasn't getting better initially. So I did schedule him 1 week later as he was improving for exploration of this in the operating room to look at that nerve better. So he didn't have cellulitis. His infection got better. So I was in a better state to be able to take him back and address this nerve, not worry about doing something in an infected environment. So did explore it. The nerve did have a stretch injury, ecchymosis, as you can see here, and some fascicular injury and loss, and extended about 2 centimeters in terms of the zone of injury. So, what we would do now? So, we could either do nothing, just close it up, nerve is grossly intact. We can cut out that damaged nerve and reconstruct it, or I could put something on the nerve to sort of, allow this to heal. And so that's what I did. Brought the operative microscope and did an intrafascicular debridement and use a nerve wrap to serve as a nerve conduit for the fascicles. And I did bridge the zone of injury, covering the 2 centimeter zone of injury. So that way the wrap would serve as a conduit to allow the fascicles to grow along the intact nerve to reach its target distally. So you can see in this scenario, we had kind of a mixed Sunderland injury of the different degrees. Now, it wasn't a very clear, straightforward, one of those. So you really have to think about how you want to manage this. So I will, end my talk here. And let me see if I can do that. Okay. And I'll have our faculty, if you want to I'm back on here, and I can ask you all your thoughts. And would you do anything different, or do anything, or do something more?
I really liked your case. I end up using allograft a lot, I think, even though I know the data on conduits for what you use is pretty good. And obviously here you're sort of doing this debridement. One of the things that I think is clever about this is whenever I get the allograft for something that's very small, I feel like I'm playing with string cheese. I'm just like peeling off fascicle by fascicle of it until I get to sort of the right size that's going to fit what I want, which is probably a bit of a waste. I guess my one question for you is do you think about where the injury is relative to flexion creases, and talk a little bit about return to movement for them? Then does a flexor tendon injury affect when you would move the finger?
Yeah, no, those are good questions. So, in this case, I think it depends what kind of wrap you have. This one actually contoured pretty well and didn't have much rigidity to it. It actually contoured pretty well and was pretty thin. So I think its ability to not impede motion would be there, but also I'm not worried about it being like a true nerve gap, like where I'd worry about like a bent conduit preventing fascicular growth, because the native nerve is still there, and that's going to stent that bent. If there was a kink, it would stent it back open. So every time you unbend the finger, I wouldn't. One thing I do like about the PN process nerve allografts or these scenarios is that you can move them back right away. So if I'm doing a direct repair, where I'm kind of trying to get together under minimal tension, I'm not going to do it under tension. But you sometimes are worried about putting that finger in full extension sometimes right away, or if you're doing it at the wrist, extending the wrist, etc. With the whether you're doing an autograft or allograft, the fact that you have a graft, you take that out of play, and you can mobilize the person and begin that right away. So I think in a flexor tendon injury in a digit, for me, like an allograft is a great option, because I think I can get the moving right away, begin my early motion protocol for the flexor tendon, and also allow that nerve to regenerate without tension.
Yeah, so it's a real live case, and I think there's a couple of really applauding things which are good. Is that when you have a laceration that is tending to go the wrong way as far as soft tissue and infection, the opportunity to intervene right away is big, because you prevent that secondary infection from occurring, and then you can actually, in your situation, a week later you can deal with the nerve. Whereas if you had to wait for another operating room or something along those lines, then you wait a little longer. It can be much harder, so that you get to a week and you have a clean bed and you can do something. I have struggled with this situation because it is great to have something around the nerve to prevent the secondary scar tissue from, let's say, infiltrating into the epineurium. And we'll hear from Chelsea on what's the best way to prevent some of that gliding in a second. But I want something that's ultra thin, let's say. So if you think about, and you move your finger, the epineurium, or some people think the mesoneurium, is super thin, right? It has some tensile characteristics, but it's really thin. And now we've imparted a pad around the nerve, which is really important, but it's, 10 times, 100 times thicker than the epineurium. And does that, and I think Nick alluded to a little bit, and I'm not quite sure how it works. I don't know what happens to these at a couple weeks. I mean, they hydrate a little bit and they get thicker, but every time you move and you're coming across a crease, does it kink in at the junction between the like the conduit or the wrap and the normal nerve? I don't know the answer to that. It'll be interesting to hear from the group. So whereas I was very ambitiously using some of these around joints, I'm a little less enthusiastic now. Now there are newer materials which could provide a little bit of a barrier that are much thinner. That might make a bit of a difference, but whatever we put around there is going to be thicker. So it's a long-winded situation, but you want to have something to protect it as you have here. What do you guys think,
John-
Nick? It's
John asked in the chat about our preferences, cutoff length for conduit, graft, and repair. Maybe you two can discuss that.
well, I'll continue as I'm on the mic here. Very little gap for conduit. A millimeter or two, almost as if I just need a little bit of help. I can't quite get it to hold with the 9.0 or the 10.0. Because you showed in one of your studies, I think this is true in clinical practice. It goes in hierarchy, and the more biology you have in there. So, some people say 5-6 millimeters. There are data that says 3 millimeters. It's very low. For me in a situation, I would say maximum 5 or 6 millimeters. Maybe in a digital nerve, but in a mixed motor nerve, very, very low. Low gap, less than 5 or 6 millimeters, just because we have other things that are more biologic to put as an interposition rather than just it would end up being fibrin, right? So the fibrin is going to fill the conduit, and then the nerve has to regenerate through fibrin. It might as well regenerate through something that's more, let's say, conductive. I think you're on mute there.
Sorry, my on mute there. Thanks. No, I agree with you entirely. So I think for a mixed motor nerve, I don't go past 5 or 6 for a pure hollow conduit. And I think for a digital nerve, I would say up to a centimeter, like I mentioned earlier. And I think from a allograft perspective, I think for a digital purely sensory nerve or whatnot, I think you can go pretty high with that. I think you can go, good 5 centimeters if you needed to, for those. We don't see too many of those, but I think, you can really be comfortable doing that. I think once you go beyond 5, even though the data shows even up to 7, if you talk to different people who have experience with, and are doing a lot of those and have those results, I think you may be able to get some reasonable results. But I think for a mixed motor nerve, I think for an allograft, I still think if it's a critically important nerve, I would go with autograft. So if you're going to lose sleep overnight about that nerve coming back, use autograft, because that way at least you have tried the gold standard. Now, if it's something that is not critically important and you can get by and do that, I would say maximum of 3 in my hands. And again, if you go by the Ranger data, you can go up to 5 and maybe even a little bit above that. But I get a little worried when I go past 3. I'd still rather do autograft in those scenarios, especially if it's an ulnar nerve. I'm a little bit more, I think a little more flexible with the median nerve in that scenario because I have good options if that were to fail in those scenarios. But I do also run it by the patient. I don't tell them you have to choose one or the other. I lay out the options and I say, like I'm telling you all right now, that this is what the autograft data is, this is what the allograft is, and I don't try to sway them on that. And sometimes some people don't want to have a area of sensory deficit on their leg or on their medial elbow if I'm using Sertal or MABC, and they say, well, I don't want that, just use the autograft, and that's their decision. So they may guide you in that. But I still think for, in general, for once you get beyond 2-3 centimeters, I think you really should be looking at autograft. So
I think what you're hearing from the sages here and moderator is that the OIT answer and the real life answer are not the same thing. So from both. And then last question on the chat here for Dr. Jain, and this is kind of a rapid fire. Your technique for securing the conduit, and would you have done the same if the injury was proximal to the common digital nerve bifurcation?
Yeah, so my answer is I don't. I used to secure the conduit with sutures. I stopped doing that because I'm trying to avoid scar tissue and I'm trying to avoid compression. One of the criticisms for conduits were that when you suture it, you don't allow for expansion. So yeah, you could suture it in a pseudo expanded manner, but I think with the conduits, if you lay them out there and you overlap them enough, and in this area there's not going to be much movement, and it actually adheres pretty firmly. Once you're past a few days there, it's going to all not really move much there. There's not much motion. So in those scenarios, I stopped suturing them, unless it's in a area when I'm really, if I'm in a rare scenario, if I'm near something that's going to physically pull it away from it, that's going to shear it off.
Great. I have as I get rolling on to mine, I have one question for Chelsea, and how do we encourage, or how often do you see these people? Because this is going to be a real scarred bed, and especially in the hand. And I just saw a patient today. Is I did this really, really nifty surgery, and then I don't get the right nerve gliding, or what. Help us on some of this if you could, real quick.
Yeah. So early referral is the number one thing. I can't express enough how important that is. A lot of times if someone gets lost in the weeds and we get them late, by the time they walk out of the OR, the scar tissue is building. So it looks great, and then all of a sudden they're like seeming stiff. So I would say like 3 to 5 days post-op. I want to see them and educate them about how, like, yes, we might have you in a protective orthosis, but I want you coming out of it 6 times a day. And they'll look at me like, are you kidding me? And I'm like, 4 to 6 times if you're in a lot of pain. But if you don't get some glide out of the tissue, then it's just going to get glued down. So I like to explain to them that the layers of the skin, we have like the muscle, the fascia, and the skin, and please, you need to glide those tendons, otherwise they're going to get totally glued down. I don't know if I answered that question.
No, that's spot on, and I'm gonna take that back and say, we do this sometimes 2 weeks, and 2 weeks is too late.
Yeah.
Excellent. Well, Harry, let's jump into your talk.
Yep. Let me find the right thing here and share this, and I'll go to slide presentation. Okay, all good. Can you see it okay, guys?
Yes, but you're not in slide presentation though. Yeah, you have to.
There we go. Thank you.
Yep.
So preparing the coaptation. So I was trying to go through this, and what can we do this a little bit different, and we'll go through some cases, and these are all my cases, and you get called to a procedure, and this is a humerus fracture with a radial nerve injury. You can see a tag suture on there. So this is there. It was open, washed out second time around, and there'll be some questions here more than answers maybe. And this is there's the one of the ends, and there's the early neuroma forming on the proximal end. Probably not worth much of it. And you ask yourself how much of that nerve is appropriate and how much isn't. Probably the intervening section isn't. And Nick will talk a little bit about how you deal with that. But the concept of one type of injury within the epineurum, perineurum, et cetera, is good from a theoretical standpoint. But I think Susan shed light that each injury or cut nerve or crushed nerve or stretch has a component of probably all of the Sunderland classifications. And how do you sort that out? What's good, what's bad, and et cetera. So I want everybody also to remember that when a nerve is cut, and when a nerve is cut and the injury is more proximal versus distal, there's anterior central cell body death up in the spine, or the DRG, depending upon what nerve it is, and the possibility of regenerating axons gets lower because of this apoptotic death, and this may explain some of the recourses afterwards. And obviously, the longer you wait, and I just put 6 months on here, is very predictive of outcome. So, as Sonu said, and when we look at each one of these, the type of injury, when we do it, the age of the individual, fascicular matching, graft type, etc., all of these are important, and probably not one single thing we do in the surgery as an isolated variable is greater than the variables of the outcome. Those are variables of the injury. So we really need to, when we're thinking about nerve surgery, look at every single one of these as we go down to try to optimize them to overcome some of these things. And it's really an exciting time because we have basic science. We have different anatomy in the donors if we're doing nerve transfers, abnormal neural anatomy at the recipient. Don't forget that the donor and the recipient in a straight nerve injury are the proximal and distal ends. So there's abnormal anatomy, as I just showed on both of those. And how do we get a chance to improve recovery? That's what we're after. It's not like a tendon, it's not like a bone. Unfortunately, we do the same procedure over and over again, or we do the same techniques, and the outcome is quite variable. And so one of the things which I found very interesting, and I did my fellowship visit, one of them on a visiting part was with a group in the Netherlands, and they were looking at the myelin count on the proximal nerve at the time of graft or repair. And if they got 25% more myelin, this was on very specific stains, they got one whole MR3 or 0.9 grade higher, which is amazing. And I came back and I said, well, that's probably much too good to be true, but let's start looking at this a little bit. And we have the ability within a spine, and I see a couple of our residents are tuned in today, and that might make them cringe that we're going to talk about SSEP with cortical brainstem and cervical responses. But then we're going to match it with the basic science of what a good nerve looks like. And you see I have here from some of the textbooks what a really good nerve looks like and what a very much neuroma or scarred nerve looks like, and how can we sort out that very first case I showed. And when we're going to try to stimulate the nerve, now you can stimulate the distal part of the nerve if it's a partial nerve incontinuity or an acute injury. But if we're going to stimulate the proximal part of the nerve to do this SSEP, we can either use a hook electrode, which are very commonly known. And you can see here, I'm trying to determine in this neuroma what's good and what's bad. We have nerve cuff electrodes here in Cleveland because we do a lot of implantation of nerves and neuroprosthetics, which then can be wrapped around the nerve and can give really high quality signal and stimulate the whole nerve, whereas you have to hold the hook. And I'll just go through an example, and this is in a brachial plexus, which is the ultimate where you don't have a lot of nerve available, so you really have to be very cautious. And you can see here, and this is a study we did, is that we cut the nerve at that location, and on the right-hand side, it shouldn't really look like any nerve. It looks like scar, and as you can see on the SSEP monitoring, it looks very much like a squiggly line. It's sort of, I think, when the Indian or the Guardians lead men on base in a game. The game's on right now, and we're up a little bit, but we're leaving too many men on base. And if we go up a little bit higher, it begins to look a little bit like nerve, but it's not complete nerve. You can see some semblance of a signal occurring here. This is cortical, brainstem, cervical again. If we go up a little bit higher, and this is what the nerve looks like on clinical, we would say, well, that looks like a pretty good nerve. And it does resemble neural elements, but albeit still not even normal. But when we stimulate it, we can get, and you can hear me get a little bit excited as my voice rate it gets a little bit louder. We begin to get a normal response, and then at that point we would say, okay, we've finally gotten to what we feel is appropriate nerve proximally. So that's in very significant in severe cases, and we know that with the cuff electrode, this is the positive response here and here. This is the stim artifact. You can see with the cuff electrode, it's much cleaner, right? Over the duration of the study. So there are some technical considerations. One would argue that the SSEP is sensory only. So we went and we did some CAT levels, which is the choline-acetylase, which is important in the motor neurons, and we found that when we cut these sections and they had very low CAT levels, it was a very proximal injury and preganglionic, and we had a good SSEP response when it was a postganglionic. So in other words, the sensory follows the motor, at least in the proximal part of the nerve, and telling you which part of the nerve is good or bad. So how do you take this to a real life, let's say, more peripheral situation? So 43-year-old, a palmar laceration occurred 4 months ago, so I'm giving you some time. She has sensation deficits in the middle and the ring finger web space, sort of only. Tenel signs very painful, some weakness to the thenar, and it's very interesting. Here we are at the distal extent of let's say the median nerve, or the transition between the nerve and the common digital on a clinical situation. And if you look here, is it where do we identify our zone of injury? A little bit, you can maybe understand that this might be the area of vascularity, as you can see on the pointer here. Here's the arch or the vessel coming across, so we have some technical hurdles in doing this. We want to obviously protect the motor branch, which appears to be intact. So I took some of those tendons in this, and I cut the distal nerve to where I thought it looked quite good. And this was sort of the best histology. And what I found was really remarkable here is that, let's say we were in the common digital area, or maybe there's some a nerve that's going to be innervating the lumbricals, whereas you would think there's two main fascicles to the radial and ulnar aspect of the respective fingers. Look at all the other things that are, the other neural elements are in here. The hypertrophic response of the perineurium, because it was months old. The neural elements look pretty good. Obviously, this is the distal end of the nerve, so they're not going to be completely normal. But I was impressed on, whereas we look at this as just two main fascicular bundles, how many other things were in there. But that's pretty good. And what we've identified in H&E staining is that when you get this slide and you have roughly 60 to 70% neural element as compared to scar, excluding the perineurium, scar in this area, that's a really good nerve, and that always corresponded with good electrophysiological testing. Proximal part of the nerve, the first time I cut it, this is what I got, and hopefully just in this brief talk you understand that doesn't really look like a normal nerve whatsoever. I cut up, and that's what it looks like on high power, a lot of something that's could be a tenocyte, it could be a neural element, it's just spindle cells. I cut up a little bit higher, and this begins to look more appropriately for the size. And again, we're probably in the motor region of some innervating some of the intrinsics. So we have multiple bundles, two main ones, third and a fourth one here, and a tremendous amount of vascularity and scar response. But we determined that was sort of appropriate. And then we went ahead and this is what it looks like on higher power. And you can see how thick that the perineurium gets. And then conduit assisted repair with a graft. And in this instance, I approximated, or I secured the proximal part of the graft. Secured the proximal part of the conduit, but not the distal aspect. So how do you bring that? This is in higher power, and you can see the coaptation. How do you bring that into something where you don't have the ability to do some of these stains? Now, this is now done on H&E stain. We don't do this on any of the horseradish peroxidase or any of the toluidine blue for the myelin. We just do H&E stain, which is quite simple. You can even do it on a frozen section. If you're at a surgery center, you have to rely on other things, how the nerve feels, the vascularity of the nerve, and I think I find that you have to let the tourniquet down and be very careful to do under a lidocaine with epi field so that you don't use a tourniquet, and you have to see reasonable vascularity in that perineurial area. And what I've learned from this is that these vessels occur in good nerve, and we saw scar often in this perineurium when the endoneurium wasn't good. So if you don't have this ability to do some of these things, and I find these really helpful, is that you need to see some reasonable bleeding or vessels in that perineurial area. So I'm going to go and I'll sort of finish up with this case here, and then we can kind of open it up to our panel to a certain extent. But a 37-year-old nice guy, he's a carpenter, he makes furniture, and he was using this really, really sharp chisel. And as he's cleaning the live wood, because he has a lot of live wood, it slips and goes right into his forearm. And I was on call. We have surgery center time the next day, and I was told he sort of has some diminished sensation over the thenar, but he's got probably a bunch of tendon lacerations, some inability to oppose the thumb, deep laceration. Here is his ED picture. No necessarily profuse bleeding, but a deep laceration that we're going to then explore the next day. You can see here the FPL probably has some issue. The index finger flexor doesn't have the middle finger flexor doesn't have the normal cascade, maybe even the small. Hopefully the thenar is okay. Radiographs are fine, so nothing down there. And intraoperative inventory is tendon lacerations, FCR, FPL, FDP, as we saw there, FTS. The palmar-cutaneous nerve is sort of avulsed, by the skin, and he's got a median nerve laceration. So this is what it looks like with the intraoperative microscope. And I'm gonna go to exit. How do I do this? I'm gonna go back to my Zoom. How do I get everybody back on the screen here? Do I still leave this on here, and then let me do this?
Right. Are you trying to exit the?
Yeah, or show this picture, but then bring everybody back in, Chris, if we could.
You can.
I can't
I
see
think.
everybody.
We
I
can.
can't see my video here. I mean, I can't see everybody, but they can see me, obviously.
We can see you if you want to go ahead and
Yeah. So it's and Sonu, you and I have talked about these cases. There's a very small section of the nerve intact. You can see I've done a little bit of intraoperative dissection. And let's say that here's it's a this is a perfect one from the pictorial diagram I showed of all the classifications of the nerve all in one. And I can tell you that this back end is intact. He's got a little piece of nerve normal, this is his nerve, which is cut, this one's cut, that one's cut, but these are intact here. And it turns out with some stim that luckily this is kind of his thenar.
Yeah, I was giving my question, which if you could identify the motor fascicles out of that.
Yeah, and I know Nick would talk about this. If you have it within a day or two, no tourniquet, obviously, you can see the tourniquet's down because of the bleeding. Either you let it up and do your tendon repair or do something along those lines. You can use some nerve stimulation because this part of the nerve, even though it's damaged, you have to go up on the milliamps on the stimulator, but you'll be able to come through some of this so that you can maybe help to identify what parts are what here. So what do you guys think about this? How would you? Oops, I'm sorry. Told you what I did.
Well, I think what a blessing that's the motor component.
Yep.
If that was the sensory component, I'd be wishing that the guy had cut his entire median nerve so I could do maybe my best transposition of the, not really transposition, but mobilize that nerve, because I think I do my best to end repair sharp lacerations. And I think you limit the number of coaptation sites, obviously, from 2 to 1 when you eliminate the grafting. And I don't think we fully know the tension data, right? We say that we don't want to sew nerves on tension, but we know that a little bit of tension might be somewhat helpful. But in this case, I think I would, if you think this is sensory, I think that I would end up grafting this. And like you, I augment my grafting with a nerve wrap to sort of protect it. And I fiber and glue them also. So belt, suspenders, and an elastic waistband approach to keeping it secure.
I like that. You can coin that phrase with the elastic waistband too. I never heard that, but that's great. No, I like that. I agree. I think, in this scenario, I think you have to just, all the principles we talked about, you apply them separately. So, the motor fascicles that you're preserving here, they're working. You stimulated them, you hyperstimulated them, you went up on the amplitude. I mean, sometimes in some of these cases, you may have to go to, your 20, milliamps on that just to really get that, to get that to, using motor stimulation for muscles to really get that to see if it stims, to really see if it works. But I think in this case, you have that intact, and then I treat the sensory portion, take it, you basically debride that out of the zone of injury to you get the healthy fascicles like you talked about earlier in your talk, the feel, the and the look of the intraneural vessels, and getting that healthy fascicular outpouching on either end of that. And then you have your true gap, and at that point you can decide, are you going to put an allograft or autograft? Because now you're looking at sensory only, so you have the option in this scenario, a little more comfort level, to put an allograft if you wanted to at a shorter gap. And then I agree with you, I would probably wrap this just to kind of hold everything in, prevent a fascicular escape, give a little, prevent other tissue from going in, and also it'll help your injured motor fascicles as well by protecting it and hopefully keeping scar tissue out of that. And again, I'm not going to go into details on the type of material for nerve wraps, because that's a whole other, you could spend half an hour to an hour talking about materials for wraps. But I agree with that. And I think, having the to seal on top of that just to kind of, lock everything into place. I think this actually goes to the other question. I'm going to steal your thunder here a little bit, but the question earlier that was asked about, do I secure these wraps with sutures? No, but on these bigger nerves, I will use tissue glue as a way to augment that. So that's my way to sort of hold the wrap in place for some of these bigger nerves.
The other thing I loved
Yeah.
about your talk with the
Go ahead. No,
the
go ahead, Nick.
histology is, Neuracus is next week, and the last Neuracus meeting we went to, a very famous nerve surgeon talked about his failures in mixed nerves with allograft and said the reason that his brachial plexus reconstructions with allografts were failing was because he didn't appreciate the quality of the nerve roots that he was grafting into, which, is pretty bold statement, I would say. But I think your histology really gives us probably the best sense of what we have. I really like that.
Yeah, thank you. And I've in a couple of these situations, I've thought to myself, and I agree with you, Nick, is that an end to end is always better because you're going to lose up to 30% of your axons at each coaptation. So, a graft, whatever. And I tried a little bit on this one, and you can see right here. So I have done this loop repair where if I can dissect the main part here away from this, and then loop this over here by itself, and then that gives me enough distance. I can maybe go end to end here. This looks pretty clean. This still needs a little bit of work. So it is a technique. And I got down into here and I just couldn't separate things appropriately. And so your intact nerve ends up, as you can see on my screen here, looping like this. And then your cut nerve, you can do sort of end to end. Let me go to the next slide. No, it's not advancing here. Why is it advancing? Oh, wait a minute. So I did a little bit of that again, right? In an attempt to mobilize that. I did what I said here, and then you can see that after all said and done, some of that nerve is pretty good in the back, and you're left with this other part. But I just couldn't mobilize it enough. And you can almost begin to see that the zone, it's amazing, probably goes from like here to, somewhere in here. And it always ends up a little bit longer than you think. And then I used nerve graft. And in this instance, and I had the discussion with everybody, and I think in these gaps, it's relatively equivalent, especially in this area where you have potential Schwann cells that are very close and still viable with some intact nerve. The allograft is somewhat very appropriate. And I didn't necessarily use a conduit in this instance because it was too close, I thought, to the wrist crease. And I'm very interested and I'm very concerned about this kinking of protective thick nerve next to very supple nerve, and then I'll use tissue in that instance. So that's that. And if you look back at some of Sunderland's wisdom, and these are these old things which you pull out, and I do a historical nerve talk, and these are things we all know about. But earlier repairs are better. One nerve coaptation is better than grafts if possible. Young do better than old. Distal repair better than proximal repair. We talked about that apoptotic thing, and I think that short grafts do better than long. And these are all very intuitive things, but I think pretty important. And just if you bring this forward, and these are the things, you only need, and this is debatable, 50% for sure, but if you get really good 30% of the nerve, you get some function. We know that. But the timing, I think, is important. I think earlier is better. I'm even doing my crush injuries like this, or that have a component of traction and crush, even gunshot wounds. I'm going quicker and quicker. We need to talk about compression trauma together and practice and study for the audience. Know your anatomy. Go to the lab. I'm always thinking about this thing in my head before I go there to make this sort of as facile as possible. So I'm gonna end there, and then we'll come back for some other stuff later on.
Awesome. Well, great talk, Harry. I think great discussion too. Well, let's Nick, we'll move on to your talk here and learn about complications.
Great. So I think you can see my slides now, hopefully. So I was tasked with talking a little bit about navigating complications. This is sort of an interesting case and pulls together, hopefully, some of the principles we've discussed tonight. Some of the goals here, we're just going to review the anatomy of the plexus. You'll be able to outline a treatment for iatrogenic nerve injuries, hopefully, and describe methods of reconstruction. So this is the case that I wanted to present. She's a 22-year-old amateur weightlifter, and for 2 to 3 years, she's had left arm, shoulder, periscapular pain, and paresthesias going down into her hand. Her paresthesias on physical examination were brought forth with deep pec minor palpation. She had negative TOS signs and normal C-spine and shoulder MRIs. Not a patient of mine, but this was the note that I read from the surgeon who diagnosed her with pec minor syndrome and indicated her for an arthroscopic pectoralis minor release. And we were sort of talking about this earlier today. This is a pretty popular technique to do this procedure. I don't have experience with doing it, so I can't speak to it. I prefer all my brachial plexus exposures open. Unfortunately, at the end of the case, as they were wrapping up the pec release, they noticed some brisk bleeding, and it was determined that a sidewall of the axillary artery was injured. So the surgeon appropriately converted quickly to a delta pectoral approach and got control of the bleeding and called in vascular surgery. And vascular surgery did a repair in the outpatient surgery center. And when she went for her imaging study post-operatively, it was found that that had clotted off. So you can see here in the CTA reconstruction, such amazing pictures we can get now. Even an orthopedic surgeon can see what's going on here, that the vessel is clotted off. And so the vascular surgeon took her back to the operating room the next day. So on the next day, he came by my booth and said, "Oh, good, Nick, I'm glad that you're still here dictating. I'm hoping you can come pop into my operating room. I think that I have some elements of the plexus that have been injured." So sort of unclear at what point this happened in the case, but you can see here clearly nerve fibers. Again, probably that clear transection of the nerve, but probably a mixed injury in some sense deeper to that. So I think this is where the next steps are really important, which is this is take your own pulse first kind of moment, I think, especially depending on where you are in practice. But it's really important, as Dr. Hoyen just said, to know your anatomy, because I think if you know your anatomy, then you can get a better sense of what's actually going on here. So took my time, found the rest of the elements of the plexus that I knew in the infraclavicular approach. So this is sort of just distal to the clavicle, of course, and that's really where you usually find the divisions. Finding the vessels helpful. And you can see in the DeBakey in the bottom, the lateral cord has been cut as it divides into the musculocutaneous nerve and into the lateral cord contribution of the median nerve. So that classic M in the plexus. And then on the deep to that is an injury, which is in continuity, but compressed, squeezed something to the medial cord. Fortunately, the posterior cord was in good shape, but you can see here the medial cord is quite thin at this level. This is an algorithm that I put together just for how I think of iatrogenic nerve injuries, and you can pull this article, and there's many more like this. I think a couple of highlights to this. The take-home point is that if you get called into, or if you notice an iatrogenic nerve injury in the operating room and you're in a place where you can have a nerve surgeon take care of it, or at least eyeball it, I think that's really helpful for sharp end-to-end laceration, or sharp lacerations that can be sewed end to end. You can do that right there. If this is noted later, then you have to have a discussion about whether you should go back. I think ultrasound is really helpful for iatrogenic nerve injuries when you're not really sure whether the nerve is actually transected or not, because if it's transected, you're going to go back earlier versus a stretch type injury. And then the other thing is about timing of EMGs. And I think in general, I wait 3 weeks or so for EMGs just to allow for Wallerian degeneration. So again, we're in the operating room. There's a complete transection of the lateral cord. There's a stretch injury, pretty severe, of the medial cord. So what do you want to do? And I think one thing that's really interesting for this, and we talked about this with the checkpoint, if you stimulate a nerve distal to the zone of injury, it's still going to fire at that immediate time period when you're in the OR that day or the next day. So just because you can stimulate with the checkpoint distal to the injury doesn't mean that the nerve's intact. For me, this is a lateral cord injury, so this is a mixed nerve. It's large. No question for me that this is even though the gap's relatively small, you can see here maybe 30 millimeters. This is an autograft for me, so I take sural nerve, I cable it. It's interesting, I've seen people cable different ways. It's fun to travel around and see this. I spot weld at the end of my coaptations, and then allow the center portion of the cables to sort of have more surface area for to survive by imbibition, but I don't have much evidence for that. And then I sew it under a microscope. This is with 9.0 nylons, but then I also put, like I said, a conduit followed by fibrin glue. So, I expect some recovery from this because it's relatively close to the zone, to the muscle that's going to innervate. But for the medial cord, I left that because I don't think that there's much chance for reinnervation. And really, I'm sort of betting on her that whatever she can get through is going to do the best for her. I did get a 3-week EMG just to help understand the injury better and the prognosis. You can see there was a pan plexus injury. The posterior cord's slightly affected here as well. We last saw her 6 months from the surgery and the repair of her arthroscopic pec minor release. She had grade 4 plus radial nerve function. So her posterior cord, like I thought in the operating room, was pretty intact and functioning well. This is Dr. Spinner saying she had grade 4 elbow flexion. Spinner's a pretty honest guy, so it seems like it's probably not just coming from the biceps, but could be brachioradialis, of course, or reverse Steinler. Trace finger flexion, no intrinsic function. And you can see here in her 6-month nerve conduction study, EMG. I think when you're doing nerve surgery and you get an EMG like this, you kind of pat yourself on the back because you can see that your coaptations worked, right? You've re-innervated the biceps. But truthfully, it's really way more important whether or not the patient can use their elbow than whether or not the EMG looks good. But the FPL coming back as well. So some early reinnervation there, but we're not seeing a lot with the first dorsal interosseous. So probably pretty severe injury on that medial cord. Plan for her is to follow up 6 more months, so follow up at a year, which actually should be coming up in the next month or so. See how she's doing, and then discuss tendon transfers for her, depending on how she's doing. So pretty challenging case, but I think highlights some important things for iatrogenic nerve injuries. I think if you're a hand surgeon, it's sort of hard for you to ever not be on call because there's always a chance that a nerve injury could creep up and they're going to want to call, you're going to be able to help somebody. And I think there's nothing more gratifying in my job than having a surgeon ask me for help and me being able to help them. Your anatomical knowledge is really key when you're trying to identify injured structures. I think electrodiagnostic studies, handheld devices like the checkpoint can be really helpful, but at the same time, nothing beats anatomy. And it doesn't, the plexus, as everybody knows, doesn't quite look like the textbook tells you that it does. And then autograft, we've mentioned this multiple times, sort of the gold standard for mixed nerve reconstruction. So I will open it up.
Awesome. A great talk, Nick. I had a question for you. So, with regard to your algorithm, when you're looking at the patient that had a iatrogenic injury, but you're not there in the hospital. That's so they come and see you in the clinic or so as a new patient, and it looked like you're if I remember correctly, it was to watch them for about 3 weeks or so. Am I reading that correctly? Potentially. So my question for you, and I get that because you want to, your goal is to try to not, is to avoid unnecessary explorations. The other thought in my mind is like, okay, if I have this fresh injury, am I going to be fighting scar tissue at 3 weeks, trying to look for something? Whereas if I go in, if this happened 2 days ago, is it better for me just to, have a reasonable, it's hard to say. I mean, let's just say you want to just be sure, you go in early and because then you can just open the wound and take a look at it depending on where it's at, and you call it a day rather than, okay, now you're at 3 weeks and the wound's kind of healed and you're going through all this, this bloody field of granulation around the wound bed and all that. I don't know. I'm just throwing it out there.
I love that question. So I have 2 thoughts to this. The first is that this is where I find ultrasound to be really helpful, because if the ultrasound shows you that the nerve's transected, then there isn't really much of a reason to wait for a prolonged period of time. You know that you're not going to get recovery from whatever it is that's transected. And I think that all of us on this phone call, at least on this panel, probably have pretty good ultrasonographers to help us with this, but I know not everybody does. The second piece is because I don't use pathology, and I'd love to hear Dr. Hoyen's thought about this. I don't know that you can correctly identify the zone of injury from maybe not a sharp, but some sort of blunt injury to the nerve before that 3 weeks is over. I think I need Wallerian degeneration to happen. I need some of the myelination that's going to die back to give me a sense of where I need to graft from. So if I need to graft, can I at 1 week be confident that I've cut back enough and that the nerve injury isn't going to proceed much more proximal. I guess the way that I think about this is be a blunt trauma injury where we wash out that hand and then we go back a week later or a day later and it's worse than it was the day before until eventually it reaches some stability. So that's sort of my thought about them, which is it's going to take some time for the full nerve injury to declare itself. Maybe not in a sharp transection, but in a blunt or a arthroscopic injury. And I don't know how that correlates with pathology.
I'll go through that. So I've, as I said before, earlier, and I think everybody agrees, earlier is better than later. And there's not much outcome difference between 1 and 3 weeks. Okay, so that I try to get to all these kind of within 3 weeks, even some of the crush injuries, because the body's response is tremendous, and I've done some electrical stimulation of the distal part, which is theoretically intact, right? So it maintains the neurotransmitters for a certain period of time. And after we always said 3 weeks, right? That's sort of been the book answer. After about 5 to 7 days, you no longer get a response on the distal nerve, unless you go way up to super physiologic 20 milliamp of stimulation. So a normal threshold on a nerve on either a research or commercially available device is about 0.5 milliamp and about 50 microseconds of pulse duration. A damaged nerve, you can go 2 milliamps, maybe 100 or 200 microsecond duration. And if you have to go way up high, then that's probably not so good. So I was always like, oh, good, I'm doing this in 2 weeks. I can tell which fascicles are which. I can match it up, and all of a sudden, zippo on the distal end. So that means I think these things occur quickly. And you can begin to tell. And after about that 3 week, 4 week, all of a sudden the case gets way more difficult, right? More scar, more things there, more. And I think we actually may resect probably some, maybe some normal nerves. So I'm, this one you could do probably a little bit quicker because it's, it was a shaver or something along those lines. But you have to prepare the family and everything else and all these sort of things. So I try to get to most of these things within 3 weeks. That's sort of my gestalt.
You won me over. I'm going to go back sooner, both of you.
Yeah.
Less scarring.
Yeah. Much easier.
Awesome.
Okay, good.
Well, Chelsea, let's go ahead and let's hear your thoughts on how we can make our nerve injury repairs and reconstructions better.
Okay, great. I'll just start this. Okay, so you guys are amazing at what you do, by the way. This is just, I'm like blown away. I didn't even know that you could do the histology portion of all this. So I'm going to go as quickly as I can. I know that we're a little bit over time, but if you have any questions, please let me know. So first is like my patient assessment. When I first get a patient for nerve rehab, and this can vary widely on what the case is, I talk to the surgeon. I talk about the strength of repair, the type of repair, is it allograft, autograft? Is it delayed, like you guys spoke earlier about? And is there a protocol or precautions they want me to follow? Is there slack in the nerve? So that being said, then I kind of assess their resting posture. Do they have an ulnar claw, a Wartenberg sign, wrist drop, and are their joints supple, or am I going to have to deal with a stiff joint later on? And of course, their active range of motion. So I don't like to overly focus on what they don't have, but I definitely need to know, like, can they move against gravity? What muscles are affected? And I'm going to be targeting the specific nerves. Do they have trace strength, or do they have nothing at all? And then when I get to sensation, I like to do 2-point. If I'm really in a pinch, I do 10 out of 10 testing. So 10 out of 10 being normal and 0 is completely dead. So I compare that to the opposite side. And if I have time, I do a Semmes-Weinstein monofilament test. I like to get these as early as possible. So that way I can compare, especially if it's a pre-op to post-op case. And then, as we all know, our patients come with their own personalities and their own motivations and social emotional factors to things. So we know that they each have their own issues, and based on pain neuroscience education, their stressors in their life are going to increase their pain and potentially hinder their recovery. So I really get to know the patient, like, what's their motivation? Do they want to hold their baby again? I've had patients say, I just want to hug my child. Do they want to return to work? And what does that work entail? And do they want to manage a household, or are they kind of person that never really managed a household? Doesn't really matter. I get into that because that's what's going to be what keeps them in therapy, and that's what's going to be what helps them do their home program. So here is my like, okay, now I've gotten to know the patient. I want to do patient-centered intervention. It's different for every person. And I'm going to start with the protocol. So this is a basic protocol for what I'm going to be addressing with each surgeon and with the patient themselves. So my big thing is write your referral and write it early. I would basically write when you get patient consent for surgery, you're writing the referral for therapy, because the last thing you want to do when you do a beautiful repair is to have it be hindered by adhesion and scar tissue, which was mentioned earlier. So when reinnervation starts to begin, you have to assess the strength, and I like to educate the patient on their expectations. Like if they're not going to be getting, if you do a graft and I educate them, you had a 4mm graft, and it really takes, it's a millimeter a day or an inch a month when you're going to be getting progress. So wherever it started out, you have to really think about how you're going to be getting your muscle back again. And if they're not going to be seeing motion, to them, it could be huge. So I like to educate them on what they're going to be able to do and set those expectations early. I also set expectations for when they can be out of the orthotic, when they can't, and precautions so that they know and they don't wreck the repair. So start with slow targeted exercise. I use bilateral motion to start the motor relearning process. So they might be moving very abnormally, especially when they have a lot of pain. So using both hands can really help. And I go from gravity eliminated, place and hold, isometric contraction to against gravity. Against gravity being 3 out of 5 muscle strength. I don't progress the resistance. This is key for other therapists. I know they go a little bit too fast, in my opinion, until you have good motor control. So good motor control against gravity, and then I go to resistance. So sensory re-education and desensitization, huge with nerves. Just a little case here. This is a revascularization, and this patient, I was educating him, please, like, be functional, do things, but he went to go take a microwave plate out, and he didn't notice how hot it was. So he had a huge blister. Please make patients aware of their precautions. This is critical when they have sensory loss. So here I took this from ASHT. It's a wonderful web of if someone has loss of sensation, you're going to be doing compensation techniques. Diminished sensation, same thing. So whether they use 2 hands, though, I make sure, like, okay, if these fingers are working, you're using that entire hand. So the other fingers are going to tell you in advance if something's too hot. Otherwise, we're just not touching hot things for a while. Be very careful around stoves and all that other stuff. Sensory re-education, we go into pretty much right away, and then same thing for hypersensitivity. And if they have hypersensitivity, I'm desensitizing right away, like first visit. So orthotics and positioning, this is going to vary depending on the stage of where I get them. But if it's right away, it's a static protective thing to protect from overstretch or deformity, to protect the repair. And I always talk to the surgeon about what kind. Here are some functional ones. So for an anti-claw, I want to make sure that they're not, also the length of the muscle is really important. So if they're sitting like this, for example, with an ulnar nerve injury for a long period of time, they're stretching out all of their tendons. So even when they do get innervation back, they might not be able to move the same way. So keeping things at length is huge when it comes to repair. This is a wonderful splint made by Debbie Schwartz, and it's for functional movement after radial nerve injury. So here I have a video of someone who had actually she's a spinal cord injury patient who had multiple nerve transfers to both arms. But here we were working on her brachialis to AIN transfer. So when you see, I'm activating it with the brachialis resistance, but she was trying to make that AIN function.
Hold it right there for me.
Not that great. Okay, but then once I put a functional orthotic on it to give her a little bit more stability, we got some good blanching at that tip, so you can see the increase in pinch. And for her, this was huge post spinal cord injury. But when we're looking at the global brachial plexus injuries, like we heard from Dr. Pulos, I go for like a baby bump or a hip carrier versus a sling. So that way they can rest that arm. We're decreasing subluxation from the shoulder, but they can then use their arm when they're ready. So I love function. Okay. So they're moving their hand. The Amatrain is a shoulder cuff. It's instead of a sling, it's protecting the shoulder against subluxation, but it's supporting it while they move. So improving functional use is huge. Okay. And then edema management, scar management, and managing neuropathic pain. I didn't have a lot of time to talk, so I kind of bundled it all together, even though it's a really big topic. I learned from Lorna Kahn for nerve transfers, and I learned from Allison Taylor for taping and decreasing pain. So tape is a huge help for me and my patients to decrease their pain. When we decrease pain, we improve their use. They're going to do their home exercise program more. They're going to move more, and that leads to function. So it's huge decrease of pain. And then I was talking to the doctors earlier today about graded motor imagery. So I had a patient earlier today that had a fractional lengthening of their FDP and FPL and a step lengthening or Z-plasty for their FDS. And this was post-stroke. So he had a lot of spasticity in his hand. He couldn't open his hand. Now his hand is more open. But I'm doing stretching, and all he says is, I just want to open my hand and close my hand. So I got him in front of the mirror, and I taught him about mirror therapy. I think education is huge on why this matters. And he was able to very basically open and close his hand, very small amounts, because he's also still so stiff. But this is a huge part of what we do. And I also had a dog bite injury, who had severe neuropathic pain, couldn't even touch her. And after we got her in front of the mirror and we did mirror therapy and taping techniques, she was able to slowly start using her hand again. And it was a huge transformation. So now she's back to work. So those are some of the things that I use on a daily basis. And that's pretty much it. If you guys have any questions, let me know. But I'll stop my share.
Awesome. Wonderful talk, Chelsea. Before we conclude, I just wanted to ask you one quick question. How soon should we be sending you nerve patients after surgery? And again, it may vary depending upon the type of surgery, but are there certain scenarios where we should be sending them to you within a week versus a few weeks versus, several weeks?
Yeah. So I think that for orthotic positioning, so what I tell my surgeon does microsurgery as well. And I think that she's worried. She says these sutures are finer than a human hair. So she's worried about moving them, and I understand. That's when I get them for orthotic positioning, education on what kind of repair they had, especially if it's nerve transfers, and edema control. So there's things that we can do right away, as long as the therapist you're sending them to understands precautions and what they can't do yet. I would say, we can do 3 to 5 days post-op, and I could take down the dressing and get them into an orthotic. Also trusting that your patient's not going to just move on us. But yeah, and then otherwise I start moving patients depending on the case. If you guys are confident in the graft and the movement of it, then I would say anywhere from 3 to 5 days if it's really good and it's strong repair and you're worried about adhesion, to 2 weeks. For those really fine microsurgeries, I do wait, like for nerve transfers, I've waited 3 to 4 weeks to move them. Awesome.
Well, thanks. Well, I think we are out of time. I want to thank our panelists, wonderful talks, great discussion. And I want to thank the audience for joining us tonight. And as mentioned earlier, you will get a link to watch this on YouTube if you want to see this again. And otherwise, good night. And thanks to our AO staff for putting this together.
Yeah, fantastic.
Recording stopped.